Welcome to video 8. In the last video, we looked at why so many people who need treatment never seek it. This video focuses on practical evidence-based ways to increase voluntary entry into care. If we want more people to enter treatment, we have to design systems that make that first step much easier and possible and seem possible to people who would benefit from such care. The starting point, as highlighted in the previous video, is simple but profound. Meet people where they are, but don't leave them there. We have to build better pathways into care that are low threshold, humane, and grounded in real world behavior, not idealized assumptions. Early engagement reduces risk, supports people taking the difficult first steps toward a healthier life. Small practical changes can make a big difference. Connecting people with recovery coaches and peers, teaching how to reduce risk, helping with basic health needs like nutrition, sleep, and a primary care checkup. Everybody has to start somewhere. These initial steps get people moving forward. This initial engagement, whether facilitated by a recovery coach, peer, addiction counselor, nurse, or doctor, builds trust, reduces fear, and create the stability people need before they can say yes to formal treatment entry. When treatment is designed around how people actually change, more people accept help, build new healthier habits, and stay engaged. Over time, that momentum adds up and the benefits grow. Now let's turn to how government policy, programs, and funding can transform the treatment system. Harm reduction informed treatment engages respectfully with people who use drugs, builds trust, and lays the groundwork for starting care. It borrows practical, low threshold approaches from harm reduction strategies to increase treatment entry and engagement while helping people make steady improvements in health, reduce drug use, and pursue recovery over time. These approaches work because they reduce fear, lower the stakes for people to ask for help, and make treatment feel possible rather than overwhelming. To reach the many people not receiving help today, policies, programs, staffing, and budgets must change. So here's what needs to happen. First, the federal government should fund the creation of 1,000 engagement and support centers nationwide. These centers would be walk-in places where anyone concerned about their drug use can get help. No preconditions, no stigma, just immediate support. The centers would offer counseling, medication starts, connections to ongoing care, and a wide range of health and social services. Same-day access, continuity of care, and realistic program expectations dramatically increase the chance that people will accept help and keep coming back for more. Barriers to rapid treatment entry must be dismantled one by one. Bureaucracies, whether in government, insurance companies, or treatment programs, must adapt to patients, not the other way around. Staffing those centers requires a major expansion of the treatment workforce. Social workers, certified counselors, nurse practitioners, and addiction physicians are all important. But key to the new center's success will be hiring staff with lived experience. So secondly, we should hire and train 100,000 new recovery coaches and peers over the next decade. Recovery coaches and peers build rapport quickly, reduce fear for new patients, and inspire hope. When a person using drugs sits down with a peer, they connect because they have been there themselves. Peers also help people stay engaged because they model what recovery could look like and provide support that feels credible and relatable. Third, patients dependent on fentanyl need access to effective medications. There are three primary medications for opioid use disorder: buprenorphine, methadone, and naltrexone. Buprenorphine and methadone are agonist treatments. They act on the same brain receptors as other opioids and at the right dose prevent withdrawal and reduce cravings without reducing the high associated with illicit drug use. Methadone is a full agonist and is dispensed under more restrictive rules. Buprenorphine is a partial agonist with a ceiling effect, which lowers overdose risk and makes it easier to use in low threshold settings. Naltrexone is an antagonist. It blocks opioid receptors so other opioids cannot attach and produce their effects. If someone is taking naltrexone, opioids they use will not have the same usual impact on their body. People won't feel a high. Uh, Long-acting formulations, weekly or monthly injections, and implants of buprenorphine and other FDA products can simplify daily life for people in recovery. Medications eliminate withdrawal symptoms and create time and space for other aspects of treatment to work. These formulations also reduce the risk of missed doses, relapse, and overdose. Long-acting options should be far more accessible in community settings, including local pharmacies and primary care clinics. The evidence is clear. Medication treatment is a standard of care and substantially reduces the risk of overdose and death. At the same time, patients should be supported in their choices, whether they prefer medication, no medication at all, short-term use, or long-term use. And with clinical guidance, they should be treated with compassion and health and social support on their priorities for their treatment. Finally, we must invest in sustained assistance, not short-term fixes. Effective treatment is a year or more for those recovering from years of chronic fentanyl or polysubstance use. People need time to stabilize their health and address trauma, mental health conditions, housing instability, and the damage accumulated over years of active drug use. Care must always be individualized to match the need and respect the perspective of those who seek care. Funding mechanisms, public, private, and nonprofit, must adapt to this reality. Limiting treatment to 30 days is a recipe for failure. Fortunately, high-quality outpatient programs are more available and less costly than long inpatient stays. Outpatient care also makes it easier for patients to see family, work, and to apply what they are learning in treatment to manage their stress and anxiety out in the real world. Uh, what ties these strategies together, engagement centers, recovery coaches, low threshold access to medications, and extended treatment, is a shift in mindset. Instead of waiting for people to proactively seek treatment, programs must evolve to reach out to all those who face addiction, not just a quarter of them. This is not easy work, but it's a hard lesson we must finally learn. In the next video, I'll turn to what happens after formal treatment ends, recovery. Ending active drug use is a huge accomplishment, but rebuilding a life requires housing, work, and a community of people can count on, and a new purpose for a new life. See you in the next video. Thank you.